In this particular section, we're going to discuss on hyperprolactinemia. Most of the times, hyperprolactinemia has a lot of causes apart from prolactinoma. So that is why it's very, very important to understand the etiology of hyperprolactinemia. Before even going to the etiology of hyperprolactinemia, let us understand the prolactin physiology first and what are the effects of prolactin. That's why we are having this hyperprolactinemia as a very significant clinical problem. So let us take prolactin physiology first. So you have hypothalamus, which is the master to the master gland, that is the pituitary. And this hypothalamus is definitely going to influence the pituitary gland. In the pituitary gland, our cell of concern right now is the lactotrophs in the anterior pituitary. Fine. So this hypothalamus is going to control the lactotrophs through a very, very, very important inhibitory signal. Remember, majority of the other cells of the anterior pituitary are controlled by the hypothalamus through stimulatory control or releasing hormones, but this lactotrophs are the ones which are predominantly under inhibitory control. So that's why you want to remember. So they are going to inhibit the lactotrophs predominantly with the help of a neurotransmitter called dopamine. Very, very, very important pathway. And this dopaminergic pathway that flows from the hypothalamus to the median eminence, where the dopamine released in the median eminence is washed away by the portal system towards the anterior pituitary. This pathway is what we refer to as something called a tubero-infundibular pathway. And this tubero-infundibular pathway is really, really important because this is one of the major dopaminergic pathways in the brain. So we'll be discussing about the dopaminergic pathways later on in the central nervous system. But right now, this is one of the major dopaminergic pathways in the brain. And this hypothalamus also can affect the lactotrophs to an extent through a stimulatory control, maybe a releasing control in the form of a hormone called thyrotropin releasing hormone or TSH releasing hormone. To recap about the TRH is one of the smallest known peptide-based hormones in the body. It has only 3 amino acids in the form of glutamate, histidine and proline. We know that already. We have studied in the chapter number 1 itself. But let us assume, like this TRH is a little non-specific. It's going to not only cause release of TSH from the anterior pituitary, it's also going to cause a little bit of release of prolactin from the anterior pituitary as well. Fine. Based on whether it's stimulatory control or inhibitory control, depending on the balance, usually it's the inhibitory control that predominates, but again, depending on the balance of how much inhibition and how much stimulation is going on, you are going to get some amount of prolactin from the lactotrophs. This prolactin, they are going to have effects on peripheral tissues. They are going to have effects on target organs. And there are 2 areas where the effects are concentrated. One is obviously, as you all expect, it's the breast tissue. And second one, they're going to have effects on the gonadal function. And let me come back to that. What are the effects of gonadal function in some time? But before that, these lactotrophs are under the inhibitory control. How? Because dopamine binds to a receptor in the lactotrophs called D2 receptors. Very, very important. These are D2 receptors, which are actually nothing but G inhibitory type of G protein coupled receptors. That's why they are inhibitory. And they're going to reduce the levels of adenylyl cyclase and cyclic AMP. That's the function of GI. We know that. Similarly, this lactotrophs are under stimulatory control by TRH, which means TRH binds to the receptors in the lactotrophs. These are TRH receptors. And what are the type of receptors are these TRH receptors? Answer is they are GQ type of receptors, which means they are going to increase the inositol triphosphate and probably diacylglycerol inside the cell. That's why they cause release of the prolactin. And prolactin per se itself is going to cause effects on the target tissues, isn't it? So how they exert their effects on the target tissues? Prolactin binds to a certain type of cell surface receptors on the target cells. That is nothing but NRTKs. These are non-receptor tyrosine kinases. We know that these non-receptor tyrosine kinases are Janus kinases. These are JAK-STAT pathway receptors. That's why I told you JAK-STAT means this TINS, TERS, GM-CSF and growth hormone. What are the TINS? This prolactin, erythropoietin, thrombopoietin, leptin. So TINS, then TERS. TERS means you have the interferons, interleukins, then GH and GM-CSF, growth hormone and GM-CSF. So these are the things that are going to act on JAK-STAT pathway. And this prolactin is going to act through this JAK-STAT pathway. Very, very important point. So what are going to be the effects on the breast? So first, prolactin is going to stimulate mammogenesis. What do you mean by mammogenesis? Mammogenesis is nothing but the breast development. That is the lobulo-alveolar growth is stimulated by prolactin. Second, they can be helpful in lactogenesis. What do you mean by lactogenesis? This is nothing but milk production. Third one, you have galactopoiesis. What do you mean by galactopoiesis? This is nothing but maintenance of milk production. So these are the three major functions of prolactin. In that, if you ask a single function that is very important for prolactin, that is going to be lactogenesis, that is milk production. That's going to be the major function. Clear? And similarly, they have effects on gonadal function also. In the gonadal function, it depends on whether it's physiologically active prolactin levels or whether it's a pathologically high prolactin. So at physiological levels, the effect of prolactin on the gonadal function is largely unknown. We don't know what are the effects of prolactin on gonadal function at physiological levels. But probably in animal models, it's been proven that they can activate the Leydig cells. They can activate the Leydig cells, which means they can stimulate spermatogenesis. Probably. But in humans, it's unconfirmed. But pathologically high prolactin, we know very well what's going to happen. Whenever the prolactin levels are more than normal, pathologically high prolactin may result in gonadal dysfunction. How? Because this prolactin at very, very high levels may act as a weak gonadotropin. At pathologically high levels, they act as a weak gonadotropin like FSH and LH, which means they give a negative feedback to the hypothalamus and they will suppress the GnRH release from the hypothalamus because they act as weak gonadotropins. Reduced GnRH means they are going to reduce the FSH and LH release also. And reduced FSH and LH is going to result in gonadal dysfunction. And this is one of the most common and the main problems with hyperprolactinemia. That's what you have to know. Okay. Then, what are the things that can inhibit or stimulus that can inhibit prolactin release? Let us go back. I had drawn here. So, what are the stimulus that can inhibit prolactin release from the lactotrophs and what are the stimulus that can stimulate prolactin release from the lactotrophs? So, first, anything that is related to the dopamine. So, we know that dopamine through tuberoinfundibular pathway and next is somatostatin. We know somatostatin is one such hormone that can inhibit release of hormones from any endocrine cell in the body. So, somatostatin both can inhibit the prolactin release. Second, drugs that have dopaminergic effects. For example, dopamine receptor agonists and probably levodopa. Dopaminergic drugs. Obviously, by logic, they have to inhibit the prolactin release. Number 3, hyperthyroidism. Especially if it's a primary hyperthyroidism, definitely there will be reduced prolactin. How? Because we know in primary hyperthyroidism, whenever T4 is high, by feedback, they will try to reduce the TRH. So, let me draw. If there is a hyperthyroidism, by feedback, they downregulate the TRH production from the hypothalamus. Clear? So, that is how you lose the stimulatory control. That's why probably you have a reduced prolactin release. Number 4, milk accumulation in the breast. Milk accumulation in the breast will result in increased intramammary pressure. Because of that, you might result in reduced prolactin. It acts as a negative feedback. Yes, lot of milk, there is no need to produce excess milk. That's the idea. And certain glucocorticoids, steroid hormones or certain glucocorticoids also may result in inhibition of prolactin release. So, these are the 5 things that is very, very important. And what are the conditions that stimulate prolactin release? what are the factors that increase prolactin release? Number one, lactation itself can increase the prolactin release. So let us divide first of all into a physiological stimulus and probably a pathological stimulus. Lactation can increase the prolactin release. And number two, nipple sucking by the baby itself can result in increased prolactin. That's again a feedback. That's a stimulus to prolactin release. Milk production reflex, isn't it? Then a lot of estrogens physiologically can increase the prolactin release. Estrogen, either you're taking in the form of a hormone replacement therapy or you're taking the form of oral contraceptive pills, doesn't matter, estrogens can increase the prolactin release. Number four, sleep can increase prolactin. The circadian rhythm can increase the prolactin release. Number five, any kind of stress to the body. Stress means in the form of trauma, in the form of surgery, or majority of the seizures or epilepsy, even though it can be put under pathological, but stress in the body. Seizures means especially the temporal lobe epilepsy. We'll discuss in the causes of hyperprolactinemia. So these can increase the prolactin release. Apart from that, even exercise is a kind of stress to the body, then sexual intercourse, all these things can, even though sexual intercourse is a physical stress, that's what I mean. So sexual intercourse can increase the prolactin release. So these are the physiological stimulus for prolactin production. What are the pathological problems? Pathologically, prolactin can be high with a lot of drugs. Can cause, which we're going to discuss in some time in the next few minutes. A lot of drugs can cause hyperprolactinemia. Number two, primary hypothyroidism, especially primary hypothyroidism, can increase the prolactin. How? It's very simple. Whenever you have a hypothyroidism, they are going to stimulate the production of TRH as a feedback. That's why. Then you can get with renal failure, that is due to reduced clearance of prolactin. And whenever you have a stark effect. What do you mean by stark effect? This stark effect can be either stark compression or it could be stark resection. Obviously, the reason is whenever you reduce the flow of the dopamine. I told you this dopamine is the major regulatory mechanism for lactotroph. Even though TRH is a very, very minor thing, but dopamine is the major regulatory mechanism for controlling the lactotroph production of prolactin. So whenever you cut the dopaminergic flow towards the lactotrophs due to some reason, because the stark is the major thing that has this control over the pituitary, like an anti-pituitary. So whenever you cut the flow of dopamine, which is a major inhibitory control of the prolactin, so you might result in excessive prolactin. Either stark compression or a stark resection may result in excessive prolactin release. So these are some of the important causes of stimulation for prolactin release. So this is about the physiology of prolactin. Now let us move on to what is really meant by hyperprolactinemia and what are the effects, and we can see it in a much integrated fashion. So now let me draw the pituitary, and we have a small group of cells here which are called as lactotrophs, we know that, and this lactotrophs is controlled predominantly by a neurotransmitter called dopamine. I'm telling this once again just to make you understand, and it's going to come from the hypothalamus. And it is not going to be released directly into the lactotrophs. They are going to be released into the median eminence, and from the median eminence, this will be washed off by the portal system towards the anteropituitary, and where they are going to exert an inhibitory control over the lactotrophs. And this dopamine is going to be synthesized from the hypothalamus from an area called arcuate nucleus. And this lactotrophs may also be controlled by a releasing hormone. We know that that is nothing but the thyrotropin releasing hormone, which is again going to be washed off by the portal system, and it stimulates the lactotrophs to release prolactin. So there is some amount of prolactin that is coming based on whether it's a stimulatory or inhibitory control which is predominating. At normal states, at physiological states, prolactin levels are majorly under the inhibitory control of dopamine. We know that. So based on this understanding, let us see what will be the causes of hyperprolactinemia. Now first one, the patient might have a prolactinoma. So that's a very straightforward cause. Prolactinoma is also referred to as a lactotroph adenoma. This lactotroph adenoma can result in excessive prolactin, okay, because they do secrete prolactin by default. Then, lot of drugs can cause hyperprolactinemia. How? A lot of drugs can cause hyperprolactinemia. So let us take dopamine first. So you have D2 receptors that are going to be the major inhibitor receptor for prolactin release. Suppose if you are giving a drug that blocks this D2 receptors, what are the drugs that block this D2 receptors? Which means I can tell D2 receptor inhibitors. There are two major drugs that are D2 receptor blockers. We know that one is the antiemetic group. We have two antiemetics that are very, very important. One is your metoclopramide and second is domperidone. Even though domperidone does not cross the blood-brain barrier by pharmacology, they can act on certain circumventricular areas and they can to an extent raise the prolactin. So that is the reason why off-label, not approved for this purpose, but off-label this metoclopramide and domperidone, since they increase prolactin, they increase milk production by default. That is the reason they can be used as secretagogues by certain pediatricians. Off-label, again not a very approved treatment for this. Off-label they can be used as secretagogues. I know the best secretagogue according to your pediatric textbooks and by logic is the site of the baby sucking the breast and the sucking effect of the baby on the nipple. That is going to cause maximum prolactin release, and that is the best secretagogue in the world for the mother. But even though this can be used as secretagogues, and a lot of antipsychotic drugs that are D2 blockers can result in hyperprolactinemia. What are the antipsychotic drugs? You can divide into first generation or typical antipsychotics, which predominantly act on the dopamine receptors, and second, you have a second generation antipsychotics, which are nothing but atypical antipsychotics, which don't predominantly act on the dopamine receptors. Typical antipsychotics are the ones that are most commonly implicated in hyperprolactinemia among the antipsychotics, whereas atypical antipsychotics are less commonly implicated for hyperprolactinemia, which means the incidence is actually high with typical antipsychotics, that's all. Best examples are haloperidol, flufenazine. All these drugs can be quoted as one of the best examples. Less common drugs, even though second generation are less common drugs, one very, very important drug is there, very commonly used also, which can cause very high prolactin levels, is risperidone. Even though less common with second generation atypical antipsychotics, this risperidone is the one that causes maximum hyperprolactinemia. You have to understand, incidence is high with first generation antipsychotics, but maximum hyperprolactinemia is actually with risperidone. But again, if you take a second generation antipsychotics as an overall entity, the incidence is less. But risperidone definitely causes hyperprolactinemia among the second generation antipsychotics, but maximum hyperprolactinemia among antipsychotics is again, in fact, all the drugs is risperidone only. And you have a less commonly used drug, that is paliperidone, that also can produce hyperprolactinemia. But risperidone, never forget, very, very high levels of prolactin. Even up to the level of an adenoma, they can produce that much high prolactin. Okay. So D2 receptor blockers. So there are certain drugs that can actually reduce the amount of dopamine that is released into the synapse, or they can reduce the dopamine production itself. What are the drugs that can reduce the release of dopamine into the synapse, and what are the drugs that can reduce the dopamine production itself? Let us take a neurological synapse for that. So this is a presynaptic terminal and this is the postsynaptic terminal. And whenever dopamine is formed, for example, any dopamine, any amine is formed, let us assume. The most important amines in the CNS are dopamine, noradrenaline. Remember, adrenaline is not generally synthesized in the CNS. The only place where adrenaline is synthesized is in the adrenal medulla. They are not actually synthesized in the CNS. So dopamine and noradrenaline, these are two major amines synthesized in the CNS. This amines has to be packaged into vesicles, isn't it? They have to be packaged into small vesicles, which are actually ready to be transported out into the synaptic space. Remember, this packaging into the vesicles is done by a protein called VMAT. That's called a vesicle monoamine transporter. There are lot of VMAT blockers. The best examples, some examples I'm telling you, there are a lot of VMAT blockers are there. Some examples are serpin, tetrabenazine. So what they are going to do is going to reduce the release of this neurotransmitters. That is why they also reduce the release of noradrenaline. That is the reason why reserpine was actually one of the antihypertensive drugs. Not commonly used nowadays, obviously, but it's one of the antihypertensive drugs once upon a time because they reduce the release of noradrenaline. Clear? So they can also reduce the release of dopamine as well, all these drugs. That is why they can raise the prolactin. So we use this principle in Parkinson's disease also. Not in Parkinson's, sorry. We use this principle in whenever you are dealing with hyperkinetic movements. Let us see in basal ganglia and associated problems. They're going to reduce the release of amines into the synaptic space. At the same time, if you are going to reduce the production of these amines itself, suppose if you are going to reduce the production of these amines itself, how is that possible? Using a drug called alpha-methyl dopa, you can reduce the production of this amines itself. How? Your amines start from tyrosine and initially they form something called L-dopa, levodopa, with the help of an enzyme called tyrosine hydroxylase. With the help of another enzyme called dopa hydroxylase, dopa decarboxylase and dopa hydroxylase, they are going to form dopamine and noradrenaline respectively. Clear? With the help of dopa decarboxylase, they form this dopamine, and with the help of dopamine hydroxylase, they form this noradrenaline. Clear? These are three key enzymes in the formation of these amines. But remember, to form adrenaline, they need another enzyme called PNMT. This is called phenylethylamine N-methyltransferase. But please do remember, this PNMT enzyme is present only in the adrenal medulla. Only in the adrenal gland and adrenal medulla you have this PNMT enzyme, which means in the CNS you cannot convert this noradrenaline to adrenaline. For example, whatever adrenaline you see in the body is solely coming from the chromaffin cells. One of the important chromaffin cell clusters in the adults is adrenal medulla. So children, a lot of chromaffin cell clusters are active. So all of this can produce adrenaline, but in adults, the only active chromaffin cell cluster is the adrenal medulla. So majority, almost, in fact, I can tell all of the adrenaline that these seen in your body is actually coming from the adrenal medulla. And more probably the chromaffin cell clusters if they are active. CNS cannot produce, or peripheral nervous system cannot, or atomic nervous system for that matter, cannot produce this adrenaline. They can produce only up to noradrenaline. Let us discuss this concept more in pheochromocytoma. But right now, what I was trying to tell is, you have an enzyme called this dopa decarboxylase. You know what is going to happen with dopa decarboxylase? This dopa decarboxylase is going to recognize this L-dopa, levodopa, and convert it to dopamine, which means they have to bind with a binding site in the enzyme, this levodopa, and they have to be converted to the dopamine. But remember, there is a drug called alpha-methyl dopa, which can fool this enzyme by resembling this L-dopa, and they can bind with this dopa decarboxylase, and they can prevent the further binding of L-dopa to the enzyme, resulting in poor conversion of dopamine and poor formation of noradrenaline, which means the CNS cannot have this adrenergic output or sympathetic output, which means that is the reason why alpha-methyl dopa reduces the central sympathetic output. Because of that, they work as antihypertensive. At the same time, they also reduce dopamine production, and that is the reason why they can raise the prolactin levels also. Clear? So these are the drugs that either reduce the dopamine release or either they release the dopamine production. Fine. So now, next thing what you have to know is the effects of Stark compression or Stark resection. These are what we call as Stark effects. A lot of other drugs are there. Let me come back to that. These are the Stark effects. What do you mean by Stark effect? It could be a Stark compression or a Stark resection. Stark resection is quite rare. It can happen in a patient who is undergoing a transfemoral surgery for resecting the pituitary tumor, or it can happen during a trauma, which is again exceedingly rare. Stark compression is a relatively common entity because even a pituitary adenoma or any other mass lesion near the pituitary region can result in compression of the stalk, especially a macroadenoma, that too a non-functioning macroadenoma sometimes can compress the stalk and can raise the prolactin. So there's a huge point associated with this macroadenoma causing stalk compression and raising the prolactin. The reason is because a macroadenoma which is non-functional, you might think it's non-functional, but still you might have an elevated prolactin, which means they don't secrete prolactin. But by virtue of this stalk compression, they reduce the dopaminergic flow into the anterior pituitary. Because of that, they might raise the prolactin. So you might falsely mistake this non-functioning macroadenoma as a functioning macroadenoma or a prolactinoma. Let us see how to differentiate later on. But it's very, very important. It might, a non-functioning or a non-secretory tumor might elevate the prolactin levels by virtue of stalk compression, not by secreting. Very important point, isn't it? So stalk effects. And whole lot of other drugs can increase prolactin. What are the other drugs? Very importantly, there is a calcium channel blocker called verapamil, which can actually increase the prolactin levels by unknown mechanism of action. We don't know how. Number two, it can happen with OCPs. Obviously, estrogen, we know it's going to increase the prolactin. And number three, opioid group of drugs. Opioids can increase prolactin. Again, probably due to the mu receptor effect, they can increase prolactin. So these are some of the other drugs that you have to know that can increase the prolactin release or prolactin levels in the body. And you know, prolactin has to be handled by the kidney, and it has to be cleared. And who's going to clear kidney? Suppose in renal failure, any form of renal failure, AK or CKD, your prolactin levels may rise because of the poor clearance. Fine. Apart from that, anything that activates the reflex arc, that simulates the release of the prolactin. So what all can activate the reflex arc? Reflex arc actually comes from the nipples by sucking some stimulation of the nipple and the related area. So what can activate the reflex arc? Chest trauma or a chest surgery can raise the prolactin. All right. At the same time, you can also activate the reflex arc through herpes zoster infection of the chest wall. Herpes zoster of the chest wall can increase the prolactin. All right. And there are some other events which can increase prolactin pathologically, like certain seizures and certain epilepsy, certain forms of epilepsy, especially those seizures or those epilepsies that are focal and that are associated with the temporal lobe. Temporal lobe can increase the prolactin levels. How? Because this temporal lobe is very close to the hypothalamus. That is the reason these temporal lobe epilepsies are very, very important, which can increase the prolactin. So these are some of the pathological causes of hyperprolactinemia. I didn't tell you very, very important point, that hypothyroidism. You know, whenever you have a hypothyroidism, especially a primary hypothyroidism, by feedback they increase the TRH. This TRH increase is actually to increase the TSH, but unfortunately this TRH can also stimulate the lactotrophs and they can increase the prolactin. So these are some of the causes. I can group these causes into multiple ways. One is the prolactinoma, second group is the drug-induced group, third one is the renal failure, fourth one is the epilepsy, and fifth one is the condition that stimulate the reflex arc, and sixth one, do not forget, that is hypothyroidism, especially primary hypothyroidism. These are 6 group of causes that can cause hyperprolactinemia. Clear? Now, why we are actually fearing this hyperprolactinemia? So, is this high prolactin going to cause some big problem to the, like patients? If at all you ask, this hyperprolactinemia is going to cause any significant effect, the first one probably you might answer, everyone answers, that they cause galactorrhea. So what is the problem with galactorrhea? Yes, it happens very commonly in females than males. For that matter, hyperprolactinemia itself is common in females compared to that of the males. Almost 80 to 95% of the patients with hyperprolactinemia are actually females only. Even a prolactinoma is common in females. So any form of hyperprolactinemia is going to be common in females than males. So again, this galactorrhea is more common to be in females compared to that of the males, whereas 90% of those with galactorrhea are females. Only 10% of the affected males will have galactorrhea. What is the problem in galactorrhea? Is it going to be a big problem? No, not at all. And You can wipe it and move on, like just for fun, but there's no big problem with galactorrhea, except for the social stigma. But they are going to result in one major problem, that is gonadal dysfunction. Very, very important problem, gonadal dysfunction. Obviously, they are going to affect both males as well as females. There's no difference in this between males and females. Galactorrhea has the difference. Most commonly, females are affected with galactorrhea, but both males and females can be affected with gonadal dysfunction. And this is the most common effect of hyperprolactinemia. You know very well why the gonadal dysfunction is there, because they are going to act as a weak gonadotropin and they are going to reduce the GnRH release, and because of that they will reduce the FSH and LH and result in gonadal dysfunction. Which means reduced GnRH means reduced FSH and LH, and reduced FSH and LH means they are going to reduce the testosterone and estrogen, that is the sex hormones. Once they reduce the sex hormones, you have a variety of problems. Clear, what are those problems? This is hypogonadotropic hypogonadism. We know that, pituitary related problem. Prolactinoma causes hypogonadotropic hypogonadism. So in females, you're going to get amenorrhea, all right? Yes, this is the most common. Then definitely they will have infertility, because they cannot ovulate, they cannot produce the menstrual cycles. How you can expect them to conceive? That's why a lot of infertility clinics, in the infertility workup, one of the first things you have to do is check for prolactin levels. They can result in loss of libido and osteoporosis. You know very well, estrogen and androgens are very, very important for bone protection. At the same time, these males can develop loss of libido, all right? They can also develop osteoporosis, and they can go for erectile dysfunction as well. So all these are problems with hyperprolactinemia. And remember, this gonadal dysfunction is the most common effect of high prolactin levels. So this is why we worry about this hyperprolactinemia. And you have to be absolutely sure there is no cardiovascular morbidity or mortality because of excessive prolactin. There's no increased cardiovascular morbidity or mortality with excessive prolactin, which means excessive prolactin doesn't kill you, but it depresses you by causing gonadal dysfunction. But it doesn't kill you really. Why I'm telling this point 2-3 times? Because there is another entity in the next topic we are going to discuss on excessive growth hormone. Excessive growth hormone is actually dangerous. They increase the cardiovascular mortality. And there are, usually any patient with excessive growth hormone has 2 times more death risk compared to that of the age-matched controls. That is why this point is important. Prolactin does not result in excessive mortality, whereas growth hormone excesses. So this is why we worry. So this is the reason and why we worry, and these are the effects of hyperprolactinemia. Okay. So how will you evaluate now? So what are the ways to evaluate a case of hyperprolactinemia? Whenever you have a clinical suspicion of hyperprolactinemia, obviously the clinical suspicion means the patient will have some gonadal dysfunction. So you suspect hyperprolactinemia. The next test you're going to do is a serum prolactin. Yes, you do serum prolactin. So what are the normal levels of serum prolactin? Normal means it is less than 20 nanograms per ml. So this is the normal serum prolactin. Anything more than 20 nanograms per ml, you're going to call it as hyperprolactinemia. Hyperprolactinemia. Does hyperprolactinemia needs MRI? Yes. Any case of hyperprolactinemia needs MRI, especially if they are not on any drugs that are known to cause hyperprolactinemia. Any patient who are not on drugs that cause hyperprolactinemia, if you see high prolactin levels, you need definite MRI. Why? Because you cannot be sure that there is no pituitary adenoma underneath. So even though there are certain cutoffs, let me tell you, for example, whenever you want to suspect a lactotroph adenoma, there is a cutoff. when can you suspect a lactotroph adenoma? Whenever the prolactin levels are more than 200, it almost always confirms that the patient is having a lactotroph adenoma, secretory adenoma underneath. There's no doubt about that. Usually benign causes will not produce this much except few causes like risperidone. But if the patient is not on any drugs and if you see a prolactin level of more than 200, definitely it is a secretory adenoma. Lactotroph adenoma is there. And even you can tell if the levels are more than 400 and the patient is not on any drugs, definitely it confirms a secretory macroadenoma. It must be a lactotroph macroadenoma. So here I can write it just confirms an adenoma, secretory adenoma, but here it confirms that it's a secretory macroadenoma. But remember, at a level of 100 or 35, you cannot rule out an adenoma. How? If the prolactin levels are only 30 or 40, it could be a non-functioning tumor by stark compression causing a mild elevation of prolactin. You cannot rule out. At the same time, an early microadenoma can produce a small elevation in the prolactin, not like more than 200. More than 200, I'm telling it confirms it's an adenoma, but I didn't tell you less than 200 rules out an adenoma. So any level of prolactin elevation, you have to rule out the adenoma in the pituitary, especially if they are not on drugs. Clear? So that is why almost all patients who's not taking any drugs has to be going for a MRI. So, but you do have certain indications for MRI. Let us see what are the indications. Number one, if the serum prolactin levels are more than 20, if it's a man with hyperprolactinemia, or if it's a premenopausal woman. Premenopausal women. Or second indication, if the serum prolactin is more than 30 nanograms per ml, if it's a postmenopausal woman. In a postmenopausal women. Third one, if the serum prolactin is more than 100 plus if the patient is taking some drug that is known to cause hyperprolactinemia, but except risperidone, where the cutoff for serum prolactin will be more than 300 plus history of taking risperidone. Because that's why I emphasize this point that much in the beginning itself, because risperidone is the one hormone that one drug that maximally elevates the prolactin among all the drugs. That's why only for risperidone the cutoff is kept at 300. So indications: prolactin more than 20 in a man or a premenopausal woman, or prolactin more than 30 in a postmenopausal woman, or prolactin more than 100 with the patient taking some drug that is known to cause hyperprolactinemia, or especially risperidone. There is an exception where the cutoff is more than 300. You have to take an MRI for these patients. Clear? So these are the indications for MRI. But before that, before going into the subsequent treatment part, you have to know one thing, of two things about this prolactin assays, two pitfalls of this prolactin assays, or you can tell two important aspects of this prolactin assay which can fool you sometimes. What are the two important aspects? That is called a hook effect, and second one is the macroprolactin. Macroprolactin. What do you mean by this hook effect? It's quite simple. So how they find out the prolactin is what you have to know. First of all, the assays, how they use the assays to find out the prolactin. Let us assume there are some prolactin molecules, and how they find out this prolactin is giving a reagent that produces cross-linking of these antibodies. Clear? So how much cross-links are generated? You can see how much cross-links are generated. This cross-links are detected by the assay, and this is the one that is going to give some level of serum prolactin. That's how they find out. But let us assume there is a very, very, very high prolactin. Like prolactin is in the range of 3,000, 6,000, even 10,000. Very high. Macroadenoma causing excessive prolactin in the particular sample. So you have a lot of prolactin, right? So when you have so much of prolactin in the sample, the antibodies will get saturated. Whatever you are adding will definitely get saturated. And you don't get enough crosslinks. Maybe you can get probably one or two crosslinks, or few crosslinks you might get, that will show a serum prolactin value either normal or only slightly elevated. But actually, the prolactin in the sample is very high. For example, the serum prolactin that is found by the assay may be just 35 or 40, mildly elevated. But actually in the sample, the prolactin may be in the range of 5,000 or 6,000. Very, very high prolactin. So this phenomenon is what we refer to as hook effect. Clear? This is a zone of antigen excess. That's what you can tell, the prozone effect. So that's what we call. So this is hook effect, and falsely a very high prolactin may be reflected as a normal or mildly elevated prolactin in the assay. So how will you find out whether there is a hook effect or not? So suspect hook effect whenever in the MRI you see a macroadenoma in the MRI, but the serum prolactin is only mildly elevated, mild increase or maybe normal sometimes. So in this condition, there are two problems. Two suspicions can be there. One differential diagnosis, probably the patient might have a non-functioning tumor, and the mild elevation of the prolactin may be due to, that is shown by the assay, may be due to Stark effect. Or if there is no Stark effect, the MRI itself will show. If there is no Stark effect, then you can suspect a functioning macroadenoma causing hook effect. But if there is some Stark distortion, then you can think about a non-functioning tumor causing Stark effect. Because of that, there is mild elevation of prolactin. Or it could be a functioning or a secretory lactotroph adenoma that is causing hook effect, not Stark effect. Hook effect, because of that, the prolactin is falsely in the lower range than what actually is. So how to differentiate this? Two differential diagnosis. Now you are going to dilute the sample and do 1:100 dilution. Suppose if you know the prolactin is only 35, if you do 1:100 dilution, the prolactin will become undetectable. If the prolactin decreases and becomes completely undetectable in the sample, or the prolactin level dramatically decreases, then whatever prolactin, the 35-40 you saw, is actually the prolactin in the sample. Now you can diagnose it's a macroadenoma that is non-functioning, and that is increase in the prolactin is due to Stark effect, probably. If the prolactin still remains the same in the sample, or even if it increases after dilution, then it is very, very clear it is a secretory or a functioning lactotroph adenoma, and the false prolactin levels that you see, falsely low prolactin levels, then you see what actually is actually due to hook effect. So that is why this is a very, very important question. If they ask you what will you do for hook effect, if you suspect a hook effect, next step to confirm this hook effect is to do 1:100 dilution. That's the idea. Okay. What do you mean by this macroprolactin? This is actually quite simple. In some patients, these prolactin molecules can be bound with this IgG. This big molecule of prolactin is what we actually refer to as a macroprolactin. Clear? This big molecule of prolactin is actually what we call it as a macroprolactin. So whenever in the sample you put this macroprolactin, they form more crosslinks. I told you it's by antibodies that we're going to find amount of crosslinks, because already they are bound with these antibodies. They produce more and more crosslinks. So it can reflect as more prolactin. So first problem is they produce increased crosslinks with the assay. Second problem is that this high molecular weight prolactin that is bound with the IgG antibody naturally in the body is going to have reduced clearance. So naturally itself, some prolactin will be high. Prolactin levels will be a little high. So combination of both these things will show a falsely high prolactin levels, serum prolactin. So this is what we refer to as a macroprolactin. But this is a harmless prolactin because they bound to something, they are not effective. They don't have any efficacy in the body. So they don't cause any problems of hyperprolactinemia, which means how you find out this? So pituitary MRI is normal, but the serum prolactin is actually elevated. So in this condition, you can suspect a probable macroprolactin. So how will you find out whether the patient is having a macroprolactin or not? This could be due to some, pituitary MRI normal with a high serum prolactin may be idiopathic hyperprolactinemia. I didn't tell you about that fact. Hyperprolactinemia may be just idiopathic due to some reason we don't know. There can be hyperprolactin. without any cause also. It could be idiopathic or can be due to some drugs or hypothyroidism, some other reason. You might have high prolactin, but pituitary MRI may be normal. So it could be due to either one of the causes mentioned, or it could be a macroprolactin existing. How will you find out whether it's a macroprolactin or not? So in this condition, the next step is to precipitate the sample with PEG. Precipitate with polyethylene glycol. Precipitate the sample with PEG. This PEG will precipitate the macroprolactin, and now you will see the actual serum prolactin. Now, after precipitating with polyethylene glycol PEG, if you still have high prolactin, then it must be due to real hyperprolactinemia, not due to macroprolactin, because this PEG will take off all the prolactin that is bound with the IgG in the sample. Clear? So, is the actual serum prolactin will be known after doing the precipitation with polyethylene glycol. Now, let us move on to the treatment of hyperprolactinemia, how you are going to manage a hyperprolactinemia. Clear? So, management of hyperprolactinemia depends on whether it's an idiopathic hyperprolactinemia or if you have a prolactinoma, if you have a tumor inside your intracranial cavity. Remember, secondary cause of hyperprolactinemia can be just managed by treating the secondary cause. You don't have any special treatment for that. Definitely idiopathic and patients who are having a prolactinoma has to be treated in their appropriate ways. Idiopathic, I'll tell you very simply, patients can be symptomatic or asymptomatic. Idiopathic, asymptomatic, just incidental detection of high prolactin need not be treated. You can just safely observe them. Symptomatic patients, obviously, like they are idiopathic, symptomatic, no tumor inside, just treat medically. The usual symptom in these patients is going to be gonadal dysfunction. That's all. So obviously, you are going to treat them medically with dopamine receptor agonists, the details of which we'll see in some time. Whenever you have a prolactinoma, so you have to classify into, again, whether they are asymptomatic or symptomatic. Symptomatic doesn't matter whether the patient is having a microadenoma or a macroadenoma. These patients has to be treated. And asymptomatic patients, again, you can divide into whether the patient is having a micro or a macroadenoma. These patients who are having asymptomatic microadenoma can be safely observed. You don't need any treatment for them. The patient is having an asymptomatic macroadenoma or any symptomatic micro or a macroadenoma has to be treated. Remember, usual symptom of a microadenoma will be gonadal dysfunction or galactorrhea, plus or minus galactorrhea, but gonadal dysfunction is the most important symptom. A patient who is having a macroadenoma or a macroprolactinoma will have a gonadal dysfunction, galactorrhea, as well as there is a lot of chances patient will have mass effects like visual field defects also, which means whatever may be the symptoms, if the patient is having a micro or a macroadenoma, if they are symptomatic, you have to treat them. So what is going to be the first line treatment? The first line treatment is going to be medical. You are going to manage medically only. Medically means you are going to give dopamine receptor agonists. These are the best drugs. Even though somatostatin receptor agonists are there like octreotide and pasireotide, we don't use in prolactinoma typically. Dopamine receptor agonists are more than effective. That's why. So dopamine receptor agonists. What are the two types of dopamine receptor agonists we have? We have ergot group of compounds and you have non-ergot group of compounds. What we ideally prefer is the ergot group of compounds. That's what we're going to prefer for the sake of prolactinoma. So ergot group of compounds means you have bromocriptine, you have cabergoline. You have pergolide also. We don't use that right now, pergolide, but these are the two drugs that are very commonly used, that is bromocriptine and cabergoline. But for all practical purposes, the best drug, if they ask you, obviously it's cabergoline because it's associated with less side effects. At the same time, it has relatively more efficacy as well. Yes. If they ask you where will you prefer bromocriptine, the only area where I'm going to prefer bromocriptine is during pregnancy. If at all I'm going to use, I'll tell you what are the indications for using. But if at all I'm going to use a dopamine receptor agonist during pregnancy, it will be bromocriptine because it has a longer experience and more safety data. But for all practical purposes, apart from pregnant patients, we are going to use cabergoline only as a first choice. If you don't have cabergoline, then you can prefer bromocriptine. But in pregnancy, you can prefer bromocriptine as the first choice because it has a longer experience, long-term data we have. That's why. I'm not telling cabergoline is teratogenic, but I'm telling bromocriptine as data for safety. That's why. Non-ergot compounds, typically we don't use for the sake of hyperprolactinemia or prolactinoma. Instead, we prefer for Parkinson's disease. There are two non-ergot compounds. You have one is called a ropinirole and second one is a pramipexole. Clear. At the same time, one important point that you have to know is this ergot group of compounds is associated with increased risk of valvular heart disease because they can cause valve fibrosis and they can produce valvular heart disease. That is the reason why you have to do echo every 2 years once if the patient is on an ergot compound for a long term. And also do remember the risk of drug-induced pleural effusion is very high with bromocriptine. You can go back to the pulmonary medicine topic and you can see in the pleural effusion, I would have told you bromocriptine associated with drug-induced pleural effusion. Very, very important point. It's an exudative effusion. Cabergoline, yes, but relatively less compared to the bromocriptine. All right. So now, if your treatment is not responding, which means first you have to know the goal. What is the goal of giving these drugs? The goal for giving these drugs is not only to shrink the tumor, but also to make the serum prolactin to the normal range. So if you don't have this, not responding, which means your serum prolactin levels are still elevated and the tumor is not shrinking in size. So definitely you have to go for transsphenoidal surgery. And if there is any evidence of residual tumor after a transsphenoidal surgery, you have to go for pituitary radiotherapy, even though it's not so good therapy. In case of residual tumor, you have to go for pituitary radiotherapy because pituitary radiotherapy, why it's not so good treatment? Because it's associated with increased risk of panhypopituitarism. That's why. So now you have treated a hyperprolactinemia due to prolactinoma as well as idiopathic cases. Now let us move on to the next very important topic, that is how will you manage a prolactinoma in a pregnancy. First, do understand a patient with a prolactinoma, because they have high prolactin, they are not going to conceive and they will be infertile, which means prolactinoma doesn't pop up all of a sudden during pregnancy. The patient will have a prolactinoma and you have to know how they conceive, then only you can understand how they will be managed during a pregnancy. Okay, so now if a patient with a prolactinoma is infertile, how you are going to make them pregnant? First, before going into that, see what is the tumor characteristic. So I can divide into two, where the patient is having a microadenoma or a macroadenoma with mass effect. Macroadenoma without mass effect. So second group, I can divide in patients who are having macroadenoma with mass effect. Clear? So in a patient who is having a microadenoma or a macroadenoma without a mass effect, can be just started with dopamine receptor agonist. Clear? So patient who is having a macroadenoma with a mass effect, first they have to go for transsphenoidal surgery, and after transsphenoidal surgery, you have to start with dopamine receptor agonist to normalize the serum prolactin immediately. So you know the reason for this treatment, whatever you give, is going to be the goal. The goal is normalizing serum prolactin, which means in a patient with a prolactinoma, normalizing the serum prolactin must make the patient fertile and they should conceive, which means they should get pregnant. They should get conceived. Suppose if the patient doesn't conceive, that may be due to two reasons. One, persistently high prolactin levels despite doing all this therapy, or patient is having normal prolactin but still the patient is infertile due to unknown reasons. In a patient with high prolactin, usually the reason is absence of ovulation because they cause hypogonadotropic hypogonadism. No FSH, no LH, no estrogen, no ovulation. So you can use some other techniques, alternative techniques like giving a clomiphene citrate to induce ovulation in these patients. So obviously at one point of time they are going to conceive. But you still have a tumor inside. Either it's just conservatively managed, or you have did a transferal surgery and then you have given a dopamine receptor agonist. So somehow the tumor is there inside, and there's history of tumor at least. So we are going to manage these patients. Remember, once the patient conceives, the most important step and most important question they are going to ask in exam, what you are going to do is stop the dopamine receptor agonist. Because you know these patients are already on dopamine receptor agonist. The moment the patient conceives, you have to stop the dopamine receptor agonist and just do a 3-monthly follow-up. You don't know how the prolactinoma will behave during a pregnancy. There is evidence that the prolactinoma remains same size, or they may increase, or they may even shrink during pregnancy, some small percentage, but we don't know how they are going to behave. That's why we are going to do a 3-monthly follow-up. Once you do a 3-monthly follow-up, you're going to ask for the symptoms, like ask for headache and test for visual field defects in these patients. So there are two options. Either the patient may remain asymptomatic or the patient may become symptomatic. If the patient remains asymptomatic, the goal is just observe and follow. No need to do anything else. So, and again, you can do the delivery as per the protocol. You can do a normal vaginal delivery, or you can go for a C-section according to standard indication. The prolactinoma itself do not form an indication for a C-section. Clear? If the patient becomes symptomatic, what you're going to do? Which means the patient is developing headache, or if the patient is developing visual field defects. What does it matter? You have to do a MRI. In the MRI, if you are seeing an expanding tumor that is associated with high prolactin levels, more than what is the baseline that you have seen before, definitely you have to restart the dopamine receptor agonist. Suppose the patient is having a headache, but the patient is not having any expanding tumor and the serum prolactin levels remains in the baseline, which means the headache might be due to some other reason, and you have to treat that reason, and you have to find out the cause, alternative cause. There you need not do a treatment for that because it's due to something else. If it's associated with an expanding tumor and high prolactin levels compared to the baseline, definitely you have to restart the dopamine receptor agonist. This is where I told you the choice here is going to be bromocriptine, because it has a good safety data and a long-term data in pregnancy. That's why. Now, the goal is again normalization of the serum prolactin and shrinking of the tumor and avoid the further expansion of the tumor. But if that doesn't happen and the tumor keeps expanding and the prolactin levels keep rising, then you have to go for transfemoral surgery in the second trimester. Transfemoral surgery in the second trimester. Clear? And this is how you're going to manage a patient who's having a prolactinoma before pregnancy and a prolactinoma during pregnancy. Clear? If it's incidental hyperprolactinemia or idiopathic hyperprolactinemia, simple protocol. Here there is no tumor. So if you don't have a prolactinoma and you have idiopathic hyperprolactinemia, and because of that the patient is infertile, and in this patients you have to just give dopamine receptor agonist and you will normalize the serum prolactin, and after normalizing serum prolactin the patient will conceive, and after the patient conceives you just stop the dopamine receptor agonist. That's it. That's the end of it. That's all. And continue the pregnancy and do delivery as per the protocol. That's it. Clear? So this is very simple and straightforward, but they will often test you on how to manage a prolactinoma during a pregnancy. The most important question and very repeated question they are going to ask is, after conception, you have to stop the dopamine receptor agonist. This is $1 million question, multiple times asked question in the exam. Very, very common question. Clear? Now you know how to manage a prolactinoma in a standard adult population and hyperprolactinemia in a standard adult population, which is idiopathic, and how to manage a prolactinoma during a pregnancy. So some important questions are there about this dopamine receptor agonist. At the same time, what will you do after conception? Stop the dopamine receptor agonist. That's also a very important question. Apart from that, the entire idea of this flowchart and the protocol is to make you understand how will you manage a case of hyperprolactinemia and a prolactinoma. Remember, secondary causes, just treat the cause. No need to do all these things. Idiopathic, I told you already, but secondary causes means you are just going to treat the cause. That's all. So with this, I think we can close down the particular section, that is hyperprolactinemia, and we can move on to the next section, that is on growth hormone excess.